Hello, welcome to a brand new medical surgical lesson. My name is Jessie Wheatley and I'll be facilitating this lesson. Please be sure that you have your accompanying notes with you, your textbook ready, and something to write with so that you can follow along with this lesson. Thank you for listening in to this lesson. This lesson focuses on the review of RN care of problems patients may encounter in regards to acute coronary syndromes. By the end of this lesson, you should be able to compare and contrast the nursing care of various acute coronary syndromes. This information should be reviewed to you. You should be able to identify clinical assessment findings relevant to each pathological process discussed in this lesson. You should be able to teach patients regarding actions on how to maintain health and well-being when diagnosed with acute coronary syndromes. Let's quickly review coronary artery disease, also called coronary heart disease or simply heart disease, as the single largest killer of American men and women in all ethnic groups. It is also the leading cause of premature permanent disability in the U.S. when the arteries that supply the myocardium are diseased, as shown in this picture. The heart isn't able to pump blood effectively to adequately perfuse vital organs and peripheral tissues. The incidence has declined over the past decade because of the effective treatment and emphasis on reduction of cardiovascular risk factors. Atherosclerosis is the primary factor in the development of coronary artery disease. We want to assess the patient for the risk factors of coronary artery disease, such as obesity, smoking, positive family history, cholesterol management, and the diagnosis and treatment of hypertension. As you remember, we want to focus on modifiable risk factors. Non-modifiable risk factors are personal characteristics that they can't do anything about, but you want to teach them about the modifiable risk factors. You want to teach the patient about angina is a pain associated with decreased blood flow from the narrowing of the arteries or to the heart muscle, and MI indicates necrosis or death of the heart muscle tissue itself. We want to promote health promotion directed towards controlling and altering modifiable risk factors like we talked about: smoking, inactivity, hypertension, diabetes, obesity, excessive alcohol consumption, cholesterol management, and stress. These patients are going to have to be able to control this. Coronary artery disease, chronic stable angina, acute coronary syndromes affect arteries, providing blood, oxygen, and nutrients to the myocardium, the heart itself. When blood flow through the coronary arteries is partially or completely blocked, ischemia or infarction may happen. We said something about ischemia. Ischemia occurs when there's insufficient oxygen supplied to meet the requirements of the myocardium tissue here. An infarction is necrosis or death that occurs from severe ischemia and prolonged, if perfusion is prolonged, causing irreversible damage to tissue. Okay, let's talk a little bit about chronic stable angina and the different anginas. Your textbook talks about that. This is just a quick review. Chronic stable angina is chest discomfort that occurs with moderate to prolonged exertion in a frequency, duration, and intensity that remains the same over time. So it's stable, it's chronic because it remains the same over time. It results in only slight limitation of activity, is usually associated with fixed atherosclerotic plaque, and it's relieved by nitroglycerin or rest, and is managed with drug therapy and rarely requires aggressive treatment. So chronic stable angina rarely requires aggressive treatment. Acute coronary syndrome describes a presentation with either unstable angina or acute MI infarction, resulting in platelet aggregation, thrombus formation, and vasoconstriction. Unstable angina is the chest pain or discomfort that occurs at rest or with exertion, causing severe activity limitation, and the attacks and intensity of the pain increase. Unstable angina describes broad spectrum of disorders, including new onset angina, variant angina, Prince-Meadows angina, and pre-infarction angina. You should be able to read more about this in your textbook. New onset angina describes a patient who has his or her first angina symptoms, usually after exertion or other increased demands. Variant angina is the chest pain or discomfort resulting from coronary artery spasms, typically occurring after rest. Women of any age experience atypical angina, often misdiagnosed and manifesting as indigestion, pain between the shoulders, and aching jaw or a choking sensation that occurs with exertion. The absence of chest pain in older adults with MI may be due to cognitive impairment or inability to verbalize sensations. We want to watch the patients with diabetes mellitus or coronary artery disease history. They may not experience chest pain or pressure due to diabetic neuropathy. Angina pain is ischemic pain, so it usually improves when the imbalance between the oxygen supply and the demand is resolved. Let's quickly review myocardial infarction, MI. Myocardial tissue is abruptly and severely deprived of oxygen in this scenario, and blood flow is acutely reduced, leading to ischemia, as you can see in the picture. Most are the result of atherosclerosis, like we talked about, rupture of a plaque, subsequent thrombosis, or occlusion of a blood flow. Other factors may be involved, such as coronary artery spasms, platelet aggregation, and emboli from neuroemboli thrombi. Infarction is a dynamic process that does not occur instantly. Rather, it evolves over a period of several hours. The actual extent of the zone of infarction depends on three factors: collateral circulation, anaerobic metabolism, and the workload demands of the myocardium. Acute MI is further divided by the American College of Cardiology into non-ST elevation MI and ST elevation MI. Patients presenting with non-ST elevation MI typically have ST and T wave changes on the 12-lead EKG. This indicates a myocardial ischemia, and cardiac enzymes may be initially normal but elevate over the next 6 to 12 hours. Patients presenting with ST elevation MI typically have ST elevation in two leads on a 12-lead EKG. This indicates MI necrotic requires immediate treatment. It requires immediate treatment. Okay, talking about patient care here, RN care for this 12-lead EKG is going to identify the leads in which the ECG changes are occurring and the location of the ischemia and necrosis. When infarction is occurring, one of the three ECG changes is usually observed. There's going to be either an ST segment elevation, a T wave inversion, or a non-ST segment elevation. Medical interventions aim to relieve pain and decrease myocardial oxygen requirements through preload and afterload reduction. Preload reduction may be cautiously attempted with diuretics or nitroglycerin. Pain relief helps to increase the oxygen supply and decrease the myocardial oxygen demand with morphine or oxygen as priorities. Patients may take nitro to relieve the episodic anginal pain. Aspirin may also be taken daily to prevent the clot and to further open up the block on the coronary arteries. You want to monitor patients receiving thrombolytics and anticoagulants for bleeding. You want to monitor patients receiving identify and interpret diagnostic values for cardiac markers such as troponins and myoglobin and other indicators of coronary artery disease. Most patients will have an abnormal cardiac rhythm. When dysrhythmias are happening, you want to identify and assess hemodynamic status and evaluate pain. Dysrhythmias are treated when they cause hemodynamic compromise, increase myocardial oxygen requirements, or predispose to lethal ventricular dysrhythmia. It's not okay that you don't know how to read dysrhythmias at this point. You need to go and look at the steps I outlined about reading dysrhythmias, and you need to be able to identify a dysrhythmia and know when to respond. Okay, you want to use the information gained from hemodynamic monitoring to titrate drug therapy. So cardiac catheterization is performed to determine the extent and exact location of a coronary artery obstruction. For diagnosis, thallium scans use radioactive isotopes may be used to assess for ischemia and necrotic muscle tissue relation changes. Other tests are described in your notes, and you need to make sure that you review those notes as well. They go in a lot more detail. Thank you for listening in to this lesson. I hope you have enjoyed this quick review of the RN nursing care for patients with acute coronary syndromes. For questions about this lesson or corresponding notes, please feel free to email me.